on silent mode during the presentations. Namaste, Vadakkam, Sastrikal, and a hearty welcome to all our dignitaries, guests, delegates, partners. With great joy and immense exultation, I feel privileged to extend a warm welcome to all present. Thank you for giving us your precious time here today. This is Chandni Sehgal, your host for the day, and I feel privileged to be part of this wonderful event. We have arrived at day two of NICE Conference 2023. A very truly blissful morning indeed, as we welcome once again the assembly of distinguished guests, worthy members of Executive Board, most prized delegates, and valued audience. Overwhelming elation sweeps us as we have gathered today to acknowledge the pool of most talented people. It is our pleasure to welcome you all to the NICE Conference Live 2023 on 28th of April 2023 in New Delhi, India. This is day two, and the meeting will be featuring a comprehensive program with eminent speakers across the world who deliver high level scientific content, perform live and recorded cases and workshops. There will be an opportunity for every practitioner to learn more about specific topics and present e-posters and interesting neurointervention cases. Starting with our first session today, I would be requesting the humble presence of the moderator with a round of applause, Rashmi Sarav and Demetrius Klee Lobes. Let's welcome our eminent moderators here on stage, followed by our panelists for the session, Uday Limai, RV Vatke, Paul Bogle, Mark Rebo, and last but not the least, Vivek Gupta. Let's welcome them with a round of applause, please. Everybody, please put your hands up in the air. I would be requesting the moderators to kindly take the lead and present the cases to you.
Okay, audible? Okay. So we welcome our panelists and we start the cases. Today we have cases from Australia and from our own Gaurav from Medanta. So we'll just see which center is ready with the case.
So this is the first case from
This is
Medanta.
Medanta.
So we did a stent-assisted coiling a few years back. So this aneurysm has recanalized. This is the recent angiogram. You can see that the aneurysm has recanalized. So let's see what the operator is going to do with this aneurysm.
So we'll be over to Medanta now. So as we see, it's a recanalized aneurysm, ACOM. I think it's Atlas. Yeah. So Atlas stent-assisted coiling was performed. So would be going over to Medanta. So any opinion from the panelists about how would we go ahead with such a case? Recanalized stent.
Yes, correct.
Hello, Gaurav. Can you hear
Hi,
us?
good morning, Lakshmi.
Good morning. So are you ready with everything?
Yes, we are ready. I saw you have seen the case.
Yes.
So it's a recanalized ACOM and the stent is in place. Now the Atlas stent was partially hanging into the ICA and she's a 37-year-old lady. Now my first question, I don't know if have you done the polling questions yet?
So will you retreat this aneurysm or not? So obviously everyone is with the opinion that we should retreat this aneurysm.
Okay, and how should I retreat this?
So what's the opinion from the house? So about the retreatment of the aneurysm? Dr. Vivek?
I think the only two options in my mind is either you just recoil it through the stent or you forget about the coils and put a FD across within the stent.
Sir, Dr. Limay, sir?
Well, I think you're going to use a flow diverter,
I think
right?
you're doing some kind of scaffolding device, and if you're using just a device, then you would use an FD, right?
So most of the people are of the opinion that either you do the flow diversion or you put some coils within it or some scaffolding device there.
Yeah. So the angle of the aneurysm is very tricky, and that's where the part which is recanalized is the part which is at a very sharp angle, and that's where it was left a little bit the last time also. So I felt that going inside the aneurysm to put coils may not again give a durable result, and we may end up back to where we are. So my plan is to start from left A2 and come back into the right A1 and deploy a Silk Vista baby there.
Okay.
Now, the only question in which I was debating is, since there is a laser cut Atlas stent in place, should I do a balloon angioplasty first to make sure that there are no struts which will prevent good opening of the flow diverter?
So we would take a poll from the house whether they believe that angioplasty should be done or not, and also from our panelists. So Dr. Farke sir, Dr. Paul. So
Yeah, actually, not very clear on anatomy, but the aneurysm looks more committed, I mean the neck, towards the right A2. And I would think that stent-assisted coiling should be good enough.
So since we have finally decided that we are going ahead with the FT, so we have to take a call whether to do the plasty before putting the FT or not, since it's a laser cut design, it's open cells, so we don't know how the struts are actually there. Some of them might be actually projecting into the lumen. So as we have seen in the poll, many of them have written this, that we don't need angioplasty before FT. But I would take opinion from the panelists. Dr. Paul, do you believe, should we do angioplasty or not?
Personally, I'm not convinced that doing an angioplasty prior to deploying the flow diverter would do very much.
Okay.
It might, theoretically it might, but there's no way to confirm, because you can't see the Atlas stents very easily on routine imaging, and the coils will be in the way as well. So there's no way that you can actually realistically confirm, because even if the balloon were to inflate and push the struts out, let's say, there's no way that you can know that those struts then haven't re-come back. And personally, I wouldn't go for a flow diverter. I would go for a braided stent plus coils. That would be my strategy, but I appreciate that there's many different ways to skin a cat.
And Dr. Mark, what do you believe? Should we do the angioplasty if we are going ahead with the FT?
I can't hear you, but I agree with the flow diverter. I think I would try it.
So Gaurav, are you there? Can you hear
Yes.
us?
So,
there is,
we thought like doing a plasty is, typically my practice is, if there is a previously deployed stent in place, I like to do a gentle plasty just to make sure that I do not encounter difficulties when I deploy the flow diverter. And I agree with Paul that there is no way we can be 100% sure that whether this plasty has really worked for us or not. So maybe more for just psychological advantage than anything. So we have a Scepter 411 in place over a synchro. The crossing was easy. That was one of the things that there's a stent in place. Whether the crossing may cause any issues, but it was okay. There's some air, I guess, in the balloon. But okay, yeah, it's opening well.
so you will be doing the angioplasty all across the stent, right?
Yes, yes.
Proximal to distal. I mean,
Yes.
distal to proximal.
Actually, distal to proximal.
So after the balloon angioplasty is performed, I hope you will be exchanging the system and taking the microcatheter.
I'm going to put an exchange support wire, and I'm going to put a headway 17 there. Maybe you can switch to another center if Australia is ready, and we will keep the exchange ready.
So as we can understand, to be sure that there is no strut projecting into the lumen, he is performing an angioplasty within the stented segment. And after that is done, he will take out the scepter and shift to the microcatheter. So in the meantime, we shift to Australia, Melbourne. Oh, he's already there. Hello, Dr. Asadi.
Can you hear us?
Dr. Hamid, can you hear us?
Hamid. Yes, we can hear you. Hamid Asadi is here in Melbourne.
Yeah,
you can hear us well?
Can we magnify this?
Yes.
We cannot see you, Dr. Hamid.
So, sorry, can you hear us there?
Yes. So is someone showing
We
the
are just
case?
going to have, it's Hamid Afedi from Melbourne, Australia. We have a fantastic team here. Some of us are outside. Our support team is around as well. Hamid Afedi, Julian Menkar, Ali Kabaza, plus our staff nurses and radiographers and our anesthetist Dr. Jeff Davis. We have a fantastic group here that they're helping us to go live. We have been working on this aneurysm for a period of time, so we have been getting the access and the rest of it. But before we start the discussion and what's our strategy and planning, our Dr. Davor outside, our fellow, is going to have a brief presentation about what the aneurysm and its sizes and planning for the treatment of it is. So we switch to Davor's presentation, if that's okay. Can you see Davor's presentation then?
It's still not visible on the screen. Can you show the presentation?
Yes, you can see the presentation.
Fantastic. So Davor, the microphone is yours, please, to start. Thank you. So Davor is my name. I'm the Neurointerventional Fellow. This is service here. We work across 2 sites here in Melbourne, Australia. These are the beautiful hospitals there. We have 3 biplanes across both sites, 4 consultant neurointerventionists, 1 fellow, and a wonderful nursing and radiographer team as well. So this is our neurovascular team. The service is led by Associate Professor Mark Brooks. We also work closely with neurosurgery with Mr. Jeremy Russell. Of course, we have wonderful nurses and radiographers that help us and support us with our cases, without which none of this would be possible. And same goes for our wonderful anaesthetic team, both the anaesthetists and the anaesthetic nurses. So this is the case here. So it's a 61-year-old lady with an incidentally found basilar tip aneurysm. She's fit and well. She lives in a cattle farm in Tasmania, which is the island down the bottom. She still runs that cattle farm, so she's very, very well. Her history, she's had a coarctation of the aorta that was treated with a TVAR stent since 2018, as well as some hypertension and Raynaud. And this aneurysm was actually incidentally found last year in 2022 when she presented with an infected graft, an infected TVAR graft, and that required descending aortic replacement that you can see there on the right. And during the workup for that, they were worried about a mycotic aneurysm. They didn't find a mycotic aneurysm, but we did find this basilar tip aneurysm. Here are some more images of that. So this is obviously very important for web sizing, which is what we're looking to do here. It's wide neck, which makes it suitable for a web, and it's 7 millimeters in width both ways and 6 millimeters in height. So as many of you would know, we would typically oversize in width and undersize in height. So you can also appreciate here that it's pointing posteriorly slightly to the brainstem. So in terms of our strategy here, here's a very similar aneurysm that we did last year that was successfully webbed. Our strategy this time will be was to go radial access, which has already been done, and we often go radial. We're not hashtag radial first, I wouldn't say, but it's certainly an important tool in our toolbox, and in this case very appropriate because of posterior circulation and also because of the aortic issues that I described previously. So our guide catheter was an Envoy DA, which is commonly used in the setting. Intermediate was a Sophia 5, and then because we sized the web to be 8 by 4 millimeters, we've got a VIA 27. So just briefly on some competitive devices that we also considered and sometimes use. If it's narrow neck, we'll often do coil only. If stent coil seems to be the way to go, we'll do that. And we typically use the Evo stent, which you can see an example of there. It's very visible and has some flow diverting properties, but is not a full flow diverter with the risk entails in the posterior circulation. Our contour device is a new device on the market that we've got a little bit of experience with. You can see that in the bottom right. That was actually a case where we call it a kitting with a web. The web was compacted and we treated the residual with contour. And then of course flow diverter is an option as well. We tend to avoid that in the posterior circulation because of perforated implants. So we can now go to perhaps some of the quick loops of how we access the aneurysm, and then we'll cut to the live team, which is about to deploy the web in the aneurysm. Thank you very much, Davor. I hope that you guys can hear us there in the conference center. So as you can see, we had a very tortuous course of vertebral artery on that right side. And as it was mentioned, there was the issue about the aorta because of the previous intervention. We avoided to go through the femoral, which has somewhat said that's actually the normal route of access for us. But we use vertebral when it's needed and indicated. So my dear colleagues here, they had access with the Envoy DA. That's one of the go-to catheters in French for us. Sometimes we use Benchmark. And then through that, we put a 5 French Sophia as the guide catheter, intermediate catheter, so that the guide catheter can go up. The point of this case was because we are sort of obliged to use a 27 system, we cannot have concurrent balloon, which is our normal practice. We normally try to have a balloon inside in situ in case of an emergency or technical need. But in this particular case, the balloon has been prepared here, as you can see, inside the bucket here, ready to be used in case of an emergency. The 27 catheter was put in inside the aneurysm. The aneurysm is slightly tilted posteriorly. That makes it slightly difficult to go to the dome of the aneurysm. The guys were successful to advance it to the mid portion of the body of the aneurysm, and that would be good enough to be placed at that position. Apparently, there is no 27 pre-shaped via. If it's needed, sometimes we have a gentle shaking, but as the esteemed colleague there, they know very well, sometimes shaking of the catheter can be even counterproductive if it rotates opposite the direction that you would like to have it. In this case, it looks like a straight axis was actually useful, and we are in place. We did a 3D. I think you guys may be able to see the 3D. If I please ask our colleagues there to put the 3D to be broadcasted. Dina, can we please have the 3D to be broadcasted there? Yep, the 3D is coming up. You can see it on the screen. These are the dimensions of the aneurysm. Slide tilt backwards, as you can see, on the lateral view. The debate was between 8x4, perhaps larger than 8x4 or 8x3. So we also entertained the possibility of using an SLS. It doesn't look like SLS to be a good size for this aneurysm, 8 cm SLS. Therefore, we settled on 8x4 at the moment. We are going to open the 8x4 device. Attempted. If it sits well, we'll take it. If there is any issues with it, then we readjust our sizing accordingly. If there is any question from the podium or the panel, please go ahead and ask the question. Otherwise, we'll turn off the sound in the room and sit relaxed and enjoy.
Hello, Dr. Dimitrios. Can you hear us? We are not able to hear you.
We can hear you. We can hear you. Please, if there is any question.
Dr. Asadi, so we saw your case. Finally, you have decided to put a web 8x4.
Sorry, what was that?
So as we can see here, your Sophia is already in the basilar and the via is in the aneurysm.
Yes, because of the back-to-back cases that we have broadcasted for you guys with the size.
So what is the size you have decided, 8x4?
8x4 is the size that we are going for, exactly, yes. We think 8x4 is a reasonable size. It may not sit all the way from the dome to the neck, but pulling it down slightly can force the neck very well. There is a potential that the calculation of the width is slightly off and we may get a bit too longer than what we want, therefore we are going to go for 8x3. But I think 8x4 would be a reasonable device for this aneurysm.
Okay.
Any other questions?
Any other question from the house? Sorry? Okay. So, Dr. Asadi, we have a question here. Why not a contour? Why didn't you think of another intrasaccular device? Or
yes,
why did you choose?
Is another option that we were thinking. I'm just standing slightly away from the colleagues not to distract them. They're concentrating, introducing the web. Contour is another device that we have started using them since last year. We have a bit of experience with it. To be really honest, I think Contour needs some improvement on delivery, specifically delivery wire and attachment system that it has, which is something that I understand that the new company is working on it to improve. For this particular case, given the expertise that we have deployed a significant number of the webs. We're getting close to more than 200 now. We feel much more comfortable with web until we have more extensive Contour experience that we can broadcast it for an audience live.
Dr. Dimitrios, would you like to make any comment? We cannot hear you, Dr. Dimitrios. We cannot hear him.
the position, this is a real crucial step here, is that how now you're basically unsheathing the device inside of the aneurysm until it will create the pop, that right now it's opening the whole device. But I think it's crucial how the microcatheter position was in the beginning, in the dome of the aneurysm, and I think was really, really well done there.
Thank you very much, Dr. Dimitris. Yes, we had it flowered and then packed it slightly further towards the dome of the aneurysm. And now I think the guys are going to do an angiographic run to see whether there is any encroachment upon the parent vessels. And if everything looks okay, we may go ahead with either detachment and a vaso CT or vaso CT and subsequently a detachment.
Great, and this is actually a crucial point, a differential between contour and web is that at this point with contour, you actually would check if the device is actually in position by tugging on the wire to see if it would be any movement on the contour, because you're only at the neck of the aneurysm with the contour device. Web, it definitely has a much bigger interaction with the aneurysm as an endosaccular device. And here they actually have a very different, the contour sticks towards the parent vessel. That's kind of, it's a rounded base. And the web, when you deploy, see here, it will actually, that little will invert into the aneurysm. So there's a big difference there. Looks like here, you are a little bit stretched, right? But once you detach, that will go into the aneurysm, and I think you're clear. It looks like both branches are open.
Yeah.
Thank you, Dr. Dimitri. Yes, I agree. It seems that we are slightly stretched inferiorly, and when we detach it, it probably reconfigure itself and recenter itself with further clearance of that left P1, which seems slightly stagnant. What I was going to do, if you allow me, we were going to enable the microphone for Dr. Kabaza and Dr. Maingard to hear what was their opinion, because I think they were in agreement with what you said as well. Can you please have the microphone on for Ali and Julian as well? Ali and Julian, do you agree with the slight stretch that you have there? And
I think if you deploy that
So are we doing the Diana CT angio, Dr. Asadi?
Maybe unloading the wire.
Yes, sorry, I wasn't sure the sound might just following related to guys. So the discussion was they agreed that the wire was slightly pulled due to the maneuver during the deployment. So they're going to release the wire slightly. And then
Dr.
what
Asadi?
they normally do, try to advance the microcatheter over the wire to detachment, so that as soon as detachment happens, so that we sort of hold the nipple while we are putting
So as we can see, he is bringing the microcatheter down. We have to expose.
Take the device down. Could you hear me there? Can I just double check, please?
So you have pushed the device a little bit into the aneurysm, Dr. Asadi?
Yes, we just relaxed the wire a bit, perhaps rather than being a positive push, it was mainly putting it in a neutral position, and we are repeating the run now.
Okay. So,
and that shows that the web is sitting nicely, and both P1s are actually flowing very clearly, symmetrically, with no delay or stagnation.
So, Dr. Asadi, at Medanta, they are ready with the flow diverter in place. So we'll just switch there to Medanta while you are doing the Dyna CT angio.
If you don't mind, we just do the detachment for you as well in 2 seconds, and then we'll give you the video, and then we'll see you back when we did the 3D. If you give us a second, we just do the detachment. Ali is proceeding towards the detachment now. As my colleague knows very well, it's very important that when you are attaching the detacher device to the end of the wire, being very mindful not to push the wire in. It's something that sometimes happens. And when we have the detachment, Normally, we avoid pulling the detaching wire down. We try to advance the catheter over it. So that now the machine has the pleasant beep of detachment. It seems that the detachment happened. We just hold the wire and advance the microcatheter because there is always a bit of a stickiness. And that stickiness might be enough for you to pull the device down and cause trouble for the parent artery. So we normally try to hold the device with the microcatheter while the wire is pulled back. And now the detachment is complete. So we can give you the video feed now for Medenta, and then after that, if you can come back to us in perhaps something around 5 minutes, then we will show you the 3D of that as well.
Thank you very
Great
much,
job,
Dr.
guys. Perfect. Thank you.
It was a very nice...
Thank you very much. Thank you, Dr.
Thank
Dimitri,
you.
and the audience, and the lady will carry on back your hand. My apologies.
So we'll be over to Medanta now. I think Gaurav's microcatheter is in position for deploying the flow diverter. Hi Gaurav, we are back to you.
Are we live now? Can we hear you? Can you hear us?
Yes, we can.
Yes. Okay, we're just flushing this. So this is what we do, the manual flushing these days. We do not do it by like force or saline, so it's quick. We exchanged the balloon with the headway. The balloon was slightly sticky, and it was good that we had a good base camp. So Infinity over Navion was a good support. Actually, today I used a new wire for exchange, which is a synchro support, and it worked very well for us. So we are planning to deploy it within the stent. The size of Silk Vista Baby is 2.75 by 15.
So what was the size of the Atlas before, which you had used?
It's a 3 millimeter Atlas.
Okay.
But the artery is like 2.5 at this point. So I do not want to put a 3.
So 2.75 is good for a 3 mm artery?
Yeah, that's what I thought too. So I'm planning to start here. Can you see the screen? I guess both the native and fluoro.
Yeah, we can see.
Yes.
Any suggestions?
Any suggestions from the panelists? Dr. Demetrius, would you like to make a comment?
Gaurav, personally, I would go probably beyond the previous device and finish after, so to cover completely the other device. But I think this may work well. You're just in a curve there. I mean, it looks like to me, at least on the image that I have, that's the only thing that I was going to suggest to start distal to the Atlas.
Anyway, I think your wish might come true because I feel it's gonna
longer stent
beyond A1 into the ICA, so I may have to take it a bit distal than what I did.
Yes. That's a good idea.
She will listen.
Go a little more even.
Okay, not so much listening. No.
Okay, still within the
Atlas. It was difficult to push beyond that. Yeah. So that's why I thought we can just...
But it's opening beautifully inside of the Atlas. Looks like now it's you have a great support. This is a very important to be able to manipulate the stent flow diverters, is to have a great support so that you're able to have to open the device very well. It looks like
now it's open up.
Yeah, now it's open.
Yes.
It's required a bit of a push and pull.
Yes, and that is essential. You know, you're going femoral, correct?
Yes.
Yeah. So sometimes when we go radial for this, you may not have as much support. So you need to be very cautious with support to be able to manipulate, especially in a situation of a previous stent in place. This is really a great job there.
Yes.
And now look at this technique to get access through the device. Actually, if you pay attention on the talk afterwards on the OCT, will show that manipulation actually helps a lot to open the device, to go back with microcatheter inside. A little bit of spasm distal, but looks.
Yeah, I'm just going to take my catheter out, give a bit of an amlodipine here.
Yeah.
So that should be okay.
It's a brilliant, you know, this device is incredible. I really always, as a flow diverter, it really changed very little the anatomy. So it's very helpful for this ACOM, PICAS, you know, it's really a great stent. Pericaloso.
Yeah, I think the use of an 017 catheter is very helpful rather than bigger catheter. So we give some nimodipine here, and
yes.
We're gonna watch for some clot formation, if it any, and that should be
Perfect.
it. So
great
maybe,
job, Gaurav.
Thank you, Dr. Dimitri. Maybe we can switch over. I don't know how to be ready with other things. We're gonna sign off from here for the first case. And then my colleague, Dr. Anshu Mahajan, will show a second case of a flow diverter, which is again a recanalized aneurysm, but that is in the second session, I guess.
Thank you, Dr. Gaurav, and a big round of applause for the Medanta for performing such a difficult case. So we'll switch to Australia now. I think by now the Dyna CT angio, so they are just doing it.
I'm not sure whether you can see us or hear us at the moment.
We can see you and hear you.
Yes.
Yes, thank you very much. So the guys are actually doing the Vago CT now. This pipeline room of ours is Icono, so the acquisition parameters are slightly different than the old Siemens machine that we had here. We normally do it as a normal CT with 20% of contrast. That's our normal protocol for our Vago CT on the Siemens machine. On Philips, we use the official Vago CT, of course. And on the other Siemens machine is with the old machine, so we do 20% on 109 kV and 20-second CT. So the CT is done. It will be coming up very soon, and then I can show you guys how we are sitting with that.
On that note, one very nice thing is to use a dual head injector to do the dilution for you. Nimoto has a really good product for that.
Absolutely, yes. If you have a dual barrel injector, that would be a very good thing, Dr. Dimitri. Yes, exactly.
I have a question for you guys.
We normally put our fellows to do the injection inside the room.
Yes. You guys, please make a comment regarding simulation. Do you guys use Sim and Cure for simulation or no?
Very good question. Very good question. I know that the trend is actually towards the Sim and Cure. Honestly speaking, I have a bit of engineering background as well. From the math perspective, I'm not quite convinced in a rigid body simulation it would actually be that accurate yet. But of course, actually, this is something that we're thinking about it in future to have it. In one of the campuses in St. Vincent's, it's one of our projects to actually have the Sim and Cure at least at the trial phase to look into it and see whether we can have some validation internally for ourselves. My pessimistic approach towards it is just because of the amount of the compaction of the devices that we can make, which is a bit unquantifiable, whether Sim and Cure can actually be that useful. But I know that colleagues are using it very successfully, therefore we are open to trial as well.
Perfect, thank you.
Thank you.
This looks very nice, and I think the concentration is great. We can see the device well and the blood vessels.
So a question to you, Dr. Asadi. So you
found
don't.
that 20% concentration is actually doing it nicely. And on the Icono, you can have a smaller field of view reconstruction for finer structures if you have suspicion as well. But looking at it, if I may just to switch it a bit, looking at it, it looks like that the nipple sitting down and there is no encroachment up on the vessels. If there was any Any suspicion about the potential encroachment, we normally try to have a down the barrel view on our lateral, just to be sure that there is no encroachment. So you can see on the parasitical view here, we can actually ascertain the fact that the vessels are open and patent. So we are happy with the results. Therefore, we are going just to finish this procedure, and then I think we'll be soon with you guys with our second procedure.
Perfect. Thank you, guys. No, I think it looks like you do general anesthesia for these cases, correct?
Absolutely, yes. For all of our aneurysms, we do general. Since COVID time, the majority of our strokes are also done under GA as well. We have a fantastic anesthetic team here, extremely supportive here, and St. Vincent's Close Campus, as well as Monash. I work at Monash as well, and they have been extremely supportive of us. So yes, that is almost always for us for aneurysms.
Thank you. I think I missed, but do you do antiplatelets or any antiplatelet regimen for these intrasacral devices?
Very good question. Apologies, we didn't put it on the presentation. Yes, we're a bit old school. We are still Plavix and aspirin. We have cartagolol as well, but due to the cost issues and public health, we try to use cartagolol very exceptionally in the circumstances that they are needed. We normally put our patients for the aneurysms on Mondays on 600 milligram of Plavix, 600 milligram of aspirin, sometimes 300 milligram if there is any concern about potential bruising for them. And then we treat them on Friday. So they're loaded on Monday, and then subsequently they get daily dose of 75 and 100, and then they get treated on Friday. And then post-op, if there is no stent needed, what we do is we normally stop their Plavix and continue them on aspirin for 1 month to 3 months. In this particular case, I will continue the aspirin for 3 months.
Perfect. Thank you. This is
Beautiful
a great tip, and no, it looks beautiful. And thank you so much for sharing this with us. And I don't know if the panel has any questions.
So I have a question, Dr. Asadi. So do you consider doing a dyna-CT angio before detachment?
That's a very good point. Yes, sometimes when we have suspicion that there is encroachment, yes, we do that. But majority of the time, if we are relatively comfortable with our positioning, we don't do it. And there is a reason for that, because we noticed that as long as you, during the procedure, that during the process that you're actually prepping for the 3D and the rest of it, keeping the device attached, sometimes you get fiber information on the device, makes the device almost not retrievable anymore. And also the fact that the movements around with the wire and catheter in place can make it slightly dangerous with an inadvertent movement of the device. So if there is no suspicion that we are going to take the device out, we'll just proceed to detach it, and we do valvo-CT just for the sake of documenting the position, and in exceptional circumstances if it needs to be extended subsequently. But if there is any doubt about the positioning, then yes, we do the valvo-CT first, and then we decide whether we want to detach or retrieve the device.
This is a very good point, guys. I really think we have emphasized that. We have seen on the contour also, if you retrieve the device, there's a high risk of thromboembolic problems because a lot of clot forms in the device. So I think if you feel that it's not going to fit well, try to do this relatively soon. Don't let the device too long inside the aneurysm and then change position if that makes sense. But I think it's a very good point.
Thank you, Dr. Asadi. And I think we should have a big round of applause for Dr. Asadi. Beautiful case.
Thank you very much. I just wanted to show you guys that the active point over the radio was nicely closed by my colleagues, Dr. Bazar and Dr. Mengor. We normally just use the Prelude sheath access, and then we use Prelude device either over the snuff box or the radial puncture if the access is through the opposite. But as I said, majority of the time for us it's femoral. Thank you very much for the time. It was an honor. We'll see you soon.
I love your table too. Very nice. The carbon fiber table.
Thank you. Thank you very much. Thank you. You're very kind.
So now
Thank you
we'll...
very much. Please do.
Thank you, Dr. Hamid, for a lovely case in the morning and a short, nice case through the radial approach. So this is the advantage of having a radial access. We quickly finish the case and patient can walk out of the cath lab.
And the interpretation of most people, and I think of the group that wrote the paper, was that where possible, you should try and stay ipsilateral, so left A2 to left A1 and things like this. And if you looked at that aneurysm recurrence, I think it was sort of on the ipsilateral side of the aneurysm. So whilst it would have been more difficult to get into the ipsilateral A2, I think that would have been personally my preferential attempt to do, and then I probably would have struggled for a long time, bailed out and gone and done exactly what he did. But that was an interesting paper looking at where you should actually deploy the flow diverter for optimal results when you're dealing with an ACOM. I don't know what other people think of that publication.
Thank you. Over to Dimitris. He's ready.
Yes. How are you guys?
Yeah, Dr.
Can you hear me? Okay. So we're gonna get started with. I think this is probably was.
I think we'll answer your question after this.
Okay. I hope you can let me know when you can hear me.
Yeah, Dimitris, we can hear you.
Perfect.
Thank you.
So we just came from WNC in Rio de Janeiro, and one of the hottest topics was the first EMAN use of neuro OCT. So that's what we're going to talk about today, is intravascular imaging, and this is really an area that when we first started thinking about what would be ideal for neuro intravascular imaging, there were all these different requirements we had to fit, and device stiffness, the tortuosity that we had to deal with neuro, not having artifacts during the navigation to neuro on anatomy, how reliable the system would be once we get in position that you actually can get imaging, the ability to have a larger field of view, the ability to have incredible spatial resolution, and be able to have a very small, navigable, very familiar to us, the sizing of the device to navigate intracranially. That was a must for us. And the ability to clear the blood. When you have the circle Willis, it's very complex to be able to clear the blood to get this image that is basically based on a light source that you need to clear the blood. And so high speed of the pullback was crucial, as well as the workflow for that. So this is actually how the platform works. It's a console that can be integrated to your Angel Suite, and this is called the VIS-AM Pro. There is a cardiology product that is a little bit bigger than the neuro product, but the neuro product is actually the same size of a synchro guide wire. And so it's extremely familiar to us, the size, and this is like very similar to a 14 system, basically. And it's been really the testing part for us was, can we navigate this intracranially without issues? So we have done cases in anterior, posterior circulation. The main issue here was that you could now use microcatheters that are very familiar to deliver the wire. So you don't need to expose directly the OCT wire for the navigation. You actually place a microcatheter just like you normally would do a navigation, and then this intravascular imaging is done inside through the microcatheter. You don't need to have this exposed if you don't want to. But the main thing about this is that the big differential is that we're getting 10 microns resolution. This is a histological view of the blood vessel wall with incredible speed. So you can do like 250 images per second. So imagine the amount of images that can be obtained. And amazing also is the diameter is of 7 millimeters. So that allows you to see some aneurysm walls, and we were really impressed with that in the first experience. So the main issue, this is how the concept works as an animation. You may have seen these videos before, but basically you have usually intermediate catheter 5/8 or so, doing an injection of contrast, and that you do the pullback of the wire in this case that has a light source, and that the image is obtained with that during that time. Extremely fast. You can see the real-time image here on this video, and you then have this type of resolution here, which is basically you can see the internal elastic membrane, which will be really crucial in one of the cases I'm going to show you, which is the ability to see if there's injury to that or not is something that many times we have a question. Also, the integrity of the vessel is really a good detail to see that. Now here, what we initially envisioned being the applications for this technology for pathology catheterization, some things we just don't understand, some inflammatory disorders, sometimes no intimal growth, things that we just don't know what we're dealing with, plaques and so forth. Device sizing is very helpful, as well as to monitor the treatment or chronic vascular changes, as well as to give an assessment of how long to keep the platelets, if an erythema is developed or not, and so forth. Now, the team, this is, of course, you know here very much everyone, Pedro, Lidik, and Vitor did the first cases from this team, but everybody, Ajit, Matt, myself, we have been all involved on the initial phase of rolling this out. Giovanni is the mastermind behind all this, so he's definitely has to be acknowledged as the engineer behind everything, and incredible support. We had to initially in the lab work out how to do the pullback, so that there are different ways to do that. But as I told you before, you can use an SL10 microcatheter to deliver the wire, and then have your intermediate catheter for injection, clearance of the blood with contrast, and then you do the pullback. Let me show you then, these are the first cases. I'm going to show you the cases from Buenos Aires, from Argentina, and as a courtesy from Pedro Lirik, and this is really an incredible case, and I hope you follow with me. This is a patient 71 years old that had an acute stroke, right MCA occlusion, and here you have an NIH of 7 presentation 6 hours after less known normal. So this is the initial MRI, 3, and now you have a mismatch, 40 mL, and this is the initial angiogram, and now you have the first pass. So you have the microcatheter CAT6. Trieve was going to be deployed here. This is the Trieve in position, and this is first pass. So now you have, unfortunately, not able to clear the clot. Next is second pass, third pass, fourth pass. So you already see where we're going here. What are we dealing with? Is this clot? Is this a plaque? Is it a dissection? I think we all have been there. Mark Ribble, I can see your face from here that you're cringing now, and you're saying like, probably should we put more stent retrievers in this, or are we doing, should we have done only aspiration? Should we place a stent? Are we dealing with, is it a clot, dissection, intracranial stenosis? This is what we're left with after 4 passes. And I think that's interesting because the patient had a TK2A recanalization, CAT scan post-op, and this is dual energy, so that's that. And this is now a 6 days angiogram post thrombectomy. And since the technology was available, there was curiosity to know what was the problem that created this difficulty in opening that. And you can see here that on the angiogram, looks like there may be, some defect there. it's unclear if this is something that it's clot residual versus a plaque or a dissection. And the OCT, this is kind of how this works. So you can see now the plugging here on the right lower corner, you can see the plugging of the system into the console. And then you come to the console, the microcatheter is in position. So now you're gonna start the pullback of this. And this is basically, you're seeing now the pullback, this is the calibration of the system. And then you're gonna be able to introduce, you can see here, right lower corner, you're getting the, it's kind of an introducer sheath, and then the wire will go inside of the microcatheter that is in position. So here, everything is very familiar to us. We basically have a microcatheter in position, and then we unsheath the microcatheter and leave the wire exposed, as you can see here. So the wire is exposed and the microcatheter is pulled back. And then at this point, you're gonna start the next step, which is the pullback. You can see here. So I think you see the wire just moved back. I'm gonna bring this back for you here so you can see how this is the pullback. The wire is just coming back into the anatomy like that. And at the same time, you can see this 1.5 is just a distal tip. And then behind that, you have the light source. So you basically went from M2 to M1 to ICA on that imaging. And this is what you see. This is the map. This is the kind of imaging you're obtaining. And obviously, you take the time to analyze this. This is going to be more and more fed into AI. So for automatic, you see the clot there. So no plaque. And this is basically the answer to everything was that all that area, this is now 6 days later, it turned out that the whole thing was still a white thrombus. So you can see here the what was inside of the vessel, and then kind of showing that it was just a very tough clot and difficult to remove, but there's no plaque, or more importantly, 4 passes with stent retriever, there's no injury that could be identified on the internal elastic membrane. So I think that this is the layer was preserved on the where the intima is. So I think this is really very helpful for us to understand some of the preconceived ideas that the stent retriever for sure will cause some damage. I think in this case, after 4 passes, we didn't see that, but we can actually probably be more sure of that as we then can see these procedures. I thought this was a brilliant case as use of intravascular imaging to understand why we had such a challenge on this case, and potentially in the future do actually in acute phase and help us to make a decision. This is another one that post-flow diverter deployment, you had the first pass here on top. You can see that there's a malposition of the flow diverter, and just by going back with the wire and doing the massage with the wire, a second pass showed that the apposition improved after that. So that's now was used a maneuver. You can do either angioplasty or use the wire massage to then improve your apposition, and you can confirm that happened. This is a case of MCA bifurcation aneurysm, and you had also carotid fenestration or dissection. Was unclear. The patient presented with TIAs, and in this case, the decision was to investigate treat the aneurysm and investigate the carotid. And this is actually M2 to M1 view, and you can see a contour device placement, and you can see the relationship between the device and the neck of the aneurysm. Something that, in many ways, I think the web device and the contour device, the resolution that you can see this, we actually can see the struts of these devices across the neck of the aneurysm. And if you think about how you do segmentation and planning of things, you can potentially use this data to much better simulate the position of the device compared to what we have the resolution today. The other thing that's very interesting as you go into the blood vessels and you can see 7 millimeters beyond that, you actually can see the arachnoid and the vessels in the subarachnoid space. So you can see perivascular anatomy, which is really something that we just don't have that view, and it is something probably we'll learn more and more as we go in the future. The lesion in the neck, it turned out to be a dissection and not a fenestration like it was thought initially. This is definitely a very odd image to understand without a movie, but it's basically just demonstrating that it was a healing dissection and not anything else that was causing that abnormal looking angiogram. This is a case of a P64 HPC flow diverter 4x15. It was placed to treat a small, here this is the pre-treatment, a small anterior parietal artery aneurysm, and then post-treatment. And then on 6 months follow-up, there was a stenosis within the flow diverter. And now what is stenosis, clot, is this intima hyperplasia or anything else, so this is the images. You can see that there's a stenosis there. I think we all see some of these, but the question is, what is that? And in this case was intimo hyperplasia, no intimo hyperplasia. You can see quite significant, and it was not symmetric, was more towards one end of that curve. You actually can map that very well and correlate with your angiogram and try to understand if it is in the outer curve, inner curve, or if it was something to do with deployment of the device, malposition. We'll learn more because this was done on the pre, was no OCT, so it was just on the post follow-up. And this is a case of a flow diverter in coils demonstrating the presence of red clot right at the neck of the aneurysm after the flow diverter placement. And so things that today we're not seeing that so much, but definitely you can appreciate that in branch points or in the aneurysm neck, clot tends to form right after, and this may be more or less depending on how the antiplatelets are in the individual. Anyway, my time is up. I wanted to share with you, we have these 2 articles that give you a good idea of everything that about intravascular image with the HF OCT. And this is really exciting. We're so happy to be able to see the first 31 cases were done in clinical setting in humans. And they so far have done really a great job in technically speaking. It worked very well, and we're able to get really useful. I just show you a glimpse of some of the things we've seen. I will be open for questions, and thank you very much for your attention.
Thank you, Dr. Dimitris. And we are enlightened with the beautiful OCT pictures and seeing inside the arteries, seeing the Sylvian fissure. It's amazing. And I think it's going to change the practice, especially in the cases where we have confusion regarding what to do and what is the actual pathology of the disease. So with this,
hello? Can you ask a question?
Any question from the house before we close this session?
Yeah, I had a question regarding in the same, can it hypothetically be used in acute stroke settings when we cross the wire? Can OCT be used in the future? But will it help us determine the amount of stenosis so that we can accordingly decide whether we should do a stent retriever technique or this suction? Because when we first cross the wire while removing, if we can get an anatomy, it will help us go with the first pass will be better.
So would you be making a comment, Dimitris?
I think that this is what we are all excited about, because you may get an insight of information that will maybe dictate how you do the treatment. So I agree with you. Obviously, this is really early stage, and I think right now we're trying to keep the same workflow we have, but add this information mostly to show safety. That was the intent of the trial right now. But the on the pre-treatment and start getting that information is extremely valuable. I agree with you.
I have a comment.
One more, can I ask?
Rashmi, yes, please.
That's an excellent presentation. Hi, Demetrius. The thing is, for intracranial stenosis, when we are confused whether it is a dissection or an ICAD or a vasculitis, so do you think OCT will help us to determine the etiology of intracranial stenosis, whether it can differentiate between atherosclerosis versus vasculitis?
Yes, absolutely. I think this is what we needed for the revisit of the problems with intracranial stenosis and the issue that we had with Sampra's trial. A lot of young patients that had some kind of intracranial stenosis, maybe it was not atherosclerosis to begin with, So I think to be able to map that disease better, if it's a problem of an inflammatory disorder versus atherosclerotic disorder, it makes a lot of sense to me. And I think we have some already evidence that this will be helpful.
Thank you.
So, just to come back to one of the points raised by the colleague regarding use of the wire acutely, there is also another technology being developed from a company called Sensome, which looks at the electrical impedance of the clot. So there's probably a few different technologies that will coalesce and probably you'll use them at different times actually. So I would have thought Sensome prior to determining what the clot constituents are, that will allow you to then pick the right equipment, and then potentially something like the OCT wire at the end to say, do I have an underlying plaque? Do I have an underlying dissection? Is there residual thrombosis? So should I be injecting TPA or putting them on antiplatelets, things like this? So I think there's going to be a combination of technologies that will allow us to further improve our results.
If I'm not wrong,
this is a great comment. If you don't mind, I think the one thing that is very interesting to that is the use of FFR. So the ability you can use the same system and we look like we'll be able to do that and add FFR to the imaging, which then gives a physiological measurement also, and to decide on gradients if you need to angioplasty or stent and so forth. So I think it's exciting. I mean, more to come. I think we've been blinded and we're very much narrow on the angio imaging. So this will definitely increase our ability to work in our field.
We don't want to look too much like cardiologists, though.
Thanks, Demetrius, for sharing this. I think I'm hearing it for second or third time. The first time I heard you speak about this was in 2018 or 19. So how far we are from commercial availability of this product? Like, how far is the runway?
Yeah, we have now in our hospital, it's commercially available and approved for cardiology.
It's got a full FDA registration? It's got a full FDA?
I'm sorry.
It's got a full FDA?
So it's through the cardiology, yes. So we have the cardiology catheter now, and we are doing cases, right now in our hospital. But for neuro catheter, we are still going through the FDA. We did an international trial now with the first 31 patients, and then we'll submit, and then the approvals hopefully will come soon for Europe, US, and then expansion, for a global. But the cardiology system is already available.
Thanks.
It's a little bit bigger catheter though, or wire.
Thank you, Dr. Demetrius. And with this, we'll close this session. And thank you for joining us, Demetrius. Bye. And thank you all the panelists for coming over for your expert opinions. Thank you very much.
Can we please have a round of applause for all our dignitaries, our panelists as well as for the moderators for curating the session so very well and so very diligently. I do have something quite special indeed for all the wonderful people who have been quite early to the hall, as we did let you know that whosoever would be coming in inside the hall before 8:10 a.m. are entitled to participate in the lucky draw. So for all those early bird who came in early, we have a surprise. We have a lucky draw happening live and loud here. And I would request the humble presence of Dr. Anil Karapurkar and Dr. Uday Limai to please join me here on stage right now as we are about to announce the winners. Can we please have the lucky draw chits here? Please come here. And I would request Dr. Anil and Dr. Uday to join me here on stage. Let's welcome our dignitaries with a round of applause, please. Thank you so much. So let me start with saying this, that you need to be physically present in the hall right now to claim your prize. Everybody's present. We have a full house. Amazing. Please come here. So I'm going to shuffle it out so that you know it's totally unbiased. Shuffle, shuffle, shuffle. And we would now be proceeding with our second prize, which is the Amazon voucher. And let's see who will be the lucky winner. So I would request Dr. Anil to please take the lead and pick out the name of the winner. And Dr. Uday will be reading out the winner's name. Okay? Okay. All right. And the winner is, for the Amazon voucher here,
Dr. Shishir Rajendra Ravikar. Shishir is not here, so someone else gets a chance.
oh, he's not here. Let me shuffle again. Dr. Anil, please take another chit out of the lot. Yes.
Okay, better luck this time for Anurag Manirata. Wow.
Anurag is present. Can we have a round of applause for a second prize winner for the Amazon voucher? Congratulations. We would like to have a picture with you, please. You can collect your prize today evening at the gala dinner. So kindly go take your seat. Thank you so much. Arey, wait, we have the announcement of the winner still pending. Now let me tell you, the first prize is going to be an iPad. How wonderful is that? So are you excited? Can I hear a yes? Come on, can I hear a yes? You might be the lucky owner of an iPad. So let's find out who the winner is going to be. Yeah, please. Doctor, please do the honors. So we have our first chit here. Okay, so, oh, okay. Let's see who the winner is going to be.
Shikhar Uppal.
He's there! The winner is here in the room. Congratulations, sir. You're the lucky winner of an iPad. Please come forward. Everybody, can we have a round of applause for the winner here? Thank you so much. Congratulations and thank you to the doctors and our eventual guests for coming in here.
Actually, you know, for the early bird prize, the first prize was a car which was given to me.
Well, that was quite a wonderful wonderful surprise element for all of you as we move forward with a note of positivity and happy vibes to our next session now. To conduct and curate the next session, I would be requesting the presence of our venerated dignitaries one more time here on stage. Our moderators being Dr. Uday Limai and Dr. Ajay Kumar. Let's welcome them with a round of applause, please. Followed by our panelists for the session, Anil Karapurkar, Osama Zedat, Nitin Dange, Rashmi Saraf, and last but not the least, Rajiv Sivasankar. So let's welcome our dignitaries with a round of applause, and I would request the moderators to kindly lead for this session forward. Thank you.
That makes sense. So go.
Yeah.
Go. Huh. So.
Hi. Oh, really? That's for the gift, I guess. Whoever forgot that one. Say you take the lead from the side. No. It doesn't hurt. You'll be here.
Okay. So we have a case ready. It's from Artemis, team led by Vipul Gupta. And Anshu is going to introduce us to the case first. Anshu?
So this is a brief history of the case. The patient is a 54-year-old gentleman presented with subarachnoid hemorrhage. You can see the subarachnoid hemorrhage. It's a grade 4 bleed. So DSA showed ACOM aneurysm and right DACA aneurysm. And there is also the right MCA trifurcation aneurysm, the two aneurysms. One is on the superior division and one is on the inferior division. So this was the ACOM and the right MCA aneurysms. So you can see this is an ACOM, it's a multilobulated aneurysm. They treated this aneurysm a few days back. You can see that the balloon assisted coiling was done. It was well packed. So this is the final run. You can see that it's a very good result. So this is an MCA trifurcation aneurysm. So you can see the two aneurysms projecting in a different direction. So let's see what they have planned for this case. So they are going to use these hardwares. So let's go to the Artemis.
Vipul, welcome to you. You're live now. Anshu has introduced your case. You hear us, Vipul? We cannot hear you.
Okay, can you hear me now?
Yeah, now better, Vipul. So Anshu
Hi,
has,
good morning, and thanks, and I will make you shortly as well. So this actually the ruptured ACOM was treated few months back, and he has largely recovered from it. And today we plan to treat the middle cerebral artery aneurysms, at least one, and both if possible in this live workshop. Okay.
Yes.
So I can you show the A-plane? Quickly show you what we have done till now. Our micro camera is already in place. Yeah, the other guiding placement on roadmaps. Second row, second. So there was a tortuous ICA. So we took a 6-7 alien over a 4-4 gap. Go next. Next. All right. And then we reformed that ICA loop. So there was good flow. Next. 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 And we have taken a 2-1 headway. Next. Yeah, next. Yeah, play on. So you can see we have navigated a 2-1 headway. The wire is in the micro, we have given a gentle curve to the microgatherer tip. Next. So usually we don't wire the aneurysms. So, and we could navigate it pretty easily into the aneurysm, the upper one. So you can see it's a trifurcation. In the middle, there is an artery coming out in between these two aneurysms as well. So we are planning to use a contour device, okay, 7 millimeter. So if it is okay, then we'll just go ahead with the device placement now.
Yes, we can go ahead.
All right, so can you just show this here?
So what is the size you are taking, Dr. Vipul? Good morning.
So we are taking 7 millimeter size contour. I think aneurysm is around 4.8 millimeter diameter, okay, with a 3.5 millimeter net. So we have taken a 7 millimeter contour. We are taking it out. To just show you, my colleague Dr. Rajnivas has just taken out the device. Yes, sir.
For the residents' purpose, can you show us the preparation of this device?
Yeah, we are trying to show that. Can you show this camera? Okay, I think, can you see it now?
Yes, we can see that.
So yeah, so we have dipped the device into the saline, and now my colleague Rajnivas will pull it into the delivery tube. One second, just one second. So it's useful to hold the tube close to the tip for it to. Now we are, yeah. So could you see that device is now in the tube? All right. Can you hear it?
Yes, sir.
So is it okay? You go ahead.
Go ahead, Vipul.
Yeah, just show the hand camera. So there, I'm going to talk much when I'm actually delivering the device for those 10-20 seconds, okay? So again, we have flushed the tubing. Yeah.
And Dr. Vipul, is this patient is on some antiplatelet therapy or something?
Yeah, we have loaded, we have given him ticagrelor yesterday, and that is basically more so in this case because the lower aneurysm is pretty broad neck.
Yes.
By any chance, we need to place a stent in emergency or something, so that's why we have loaded with ticagrelor. Okay, and as I said, this is many months after the SAH, so it's pretty safe to do so. Oh. We can do that better. Yeah, I'm done.
Can we show the screen, please?
Yeah, can you show the A plane now? Go. बोलो A plane with hands in it. उनका एक जना अंदर है. Show the other plane. Yeah, no, it's fine.
Mic on करो.
Yeah. It's important to control the microcatheter movement at times when you're taking the device. As we saw, it came back. And now I'm actually pulling back gently when I'm taking the device in. So we can keep calibrating with the other hand while with one hand I'm pushing the device in. There's some problem with the guiding that is something like that.
Actually, there is a proximal loop, so that must be creating problem.
It's okay. We have to just be patient here and yeah. Okay, I switch to fluoro. And
A-plane fluoro.
मेरा माइक है
Somebody's head is coming in between the camera and screen. Yeah. Yeah, now it's okay. So, Dr. Vipul, you must be having access to both the smart mask as well as the native image. We are seeing the native image only.
You can give, rather than the hand, change to A-plane roadmap and A-plane fluoro. Like you shifted, like you
एक मिनट को आप एयरप्लेन दिखा दो जरा नहीं एयरप्लेन रोड में दिखा रहे हैं ऑलराइट एंड वो भी दिखा दो एक बारी बी प्लेन का ये दिखा सकते हैं या डीएसएम दिखा डीएसएम forward
native
back forward हाँ सब कन्वर्ट कर दो तो माइक्रो अंदर लेते हैं
So, Dr. Vipul, you are okay with this position or you are pulling back a little?
Yeah, we are pulling the device back a little.
Okay. Okay. Okay.
To oppose the
Neck.
walls of the aneurysm. Better.
Sorry? Internal letter. I think it's. Could you see? Can you turn my mic on? Hi. So can you see? We pulled it back a bit. You know, it wasn't completely open, and now we will do a DSA, and if need be, we'll do a.
Oh, sorry.
So and then we'll do a expressity angio just to see how it is. Okay. Because of the tortuosity, the one-to-one movement is not really there. So.
Need to?
Okay, so just let me pull it back. Okay, let's do a CD angio.
Express CT and reading.
So now we'll do a expressity angiogram.
Vipul, so now by the time that you're doing the vaso CT, may I involve our panelists? At this point of time, the first question is, of course, about the choice of treatment, like intrasaccular versus the usual choices. And he has gone with intrasaccular for the simple reason is that if it can cover the neck, then we can do the same on the other side, plus SOS, stent, or flow diameter, whatever he chooses in the middle. Would you choose any other strategy here? His primary strategy is intrasaccular. I know how Nitin feels, but Sir, Dr. Kalapurkar?
These are difficult aneurysms, and the tortuosity obviously adds to the difficulty. He has managed to get the DAC up, keeping the curves intact, which is sometimes very difficult, but he has managed that. So I think his strategy now would not be bad, but to begin with, I would have thought this would not be very difficult surgically, because they are both, one is on the bifurcation, the other is on a branch, and now they would be like an unruptured aneurysm. So this would, I don't think surgically be very difficult.
Okay, Nitin, would you be happy with the opening of the device here?
So I think so. If you watch carefully at the neck, a little bit of dog hair is left, especially on the distal branch. So I would be happy a little bit pulling it down, definitely.
Okay, further down.
Yeah, further down. And my strategies all the time is I keep the marker a little bit in the parent vessel so that the neck is covered. What we see and the flanges of the contour, which are not very well opposed, seen in the lumen where the origin of the aneurysm is. So I pull it a little more down, not worrying about the thrombosis.
Okay.
You are Nitin? Okay. Nitin, can you hear us?
Yes.
You're absolutely right. We saw what you have mentioned. The only problem which I am facing is I have very shoal. Okay? Because even taking the device, there was a lot of resistance, guiding was backing off. And so I pulled it back. My worry is that I don't have control. When I pull back further, it may just come out too much. So let me see. I know what you're mentioning is the perfect thing to do, but I'm giving it time because we had pulled it back. Maybe we'll settle down. We'll do the CT angio and see. But I absolutely agree with actually what you are saying. That ideally, even I would have liked it like a half a millimeter below from where it is at this point of time.
Absolutely.
But whether I can manage it, I have a little doubt with control at this point of time. Okay? Let us see. We'll just show you in a short while the CT angio and see how is it really looking. Oh yeah. Can you see this picture?
Yep. It's
Yes,
pretty
yes,
good. It's pretty good.
Can they hear me?
Yeah, it's pretty good.
Can they hear me?
Yeah. Vipul, we see it well. So you're doing this basically whether to decide.
Yeah, so here actually it is showing what Nitin was mentioning,
Yeah.
And which we also saw. Little bit dog ears left. We can try to pull back it a shade more, okay? And maybe that will be the ideal for the patient, okay? Whether I can do it with control, even I have little doubt, because you saw even with the Navian, with the Neuron Max in the ICA, with the Navian high up, there is a lot of friction and resistance in the system. So let us see how it goes. I will try a shape, but if I feel that I'm not having control, I may leave it here. I mean, not perfect, but I may have to live with it. Okay? Yeah, let us see.
If you pull those cases, if you pull down on the marker band and you herniate it into the parent artery, do you usually have those patients on dual antiplatelet also? Because when you bring the braids down in a wide neck, you have a risk of occlusion, right, and thrombosis in those cases.
I mean, whatever our experience is, like we bring it quite a bit in the lumen, the marker, and we have seen no thrombosis. And I give antiplatelets only for 2 days. In case you require a stent or cover later.
I mean, couple of other comments, just for the sake of discussion and the approach that you guys mentioned, what else you could treat it with? You could consider pulse rider, right? This is a tough one for stent-assisted coiling or balloon because the takeoff of the M2s are backward. And when the takeoff of the M2s are backward, it's hard to really get access. You can push your luck by looping inside the aneurysm, and then you have to use, in my opinion, the softest tip micro wire. I like when I herniate an aneurysm to use a Traxxas wire. I may have mentioned that. Of course, the clipping is another choice.
And what about your choices of antiplatelet here, Rashmi?
So normally we give antiplatelets for at least 4 weeks.
4 weeks.
Single antiplatelet. So we load them with double antiplatelet on the day of the procedure if they are ruptured, just before induction. If they are unruptured, then 1 day prior. And after the procedure, if during the procedure we didn't require any stent or anything, no thrombus, then we switch to single antiplatelet and we keep them for 4 weeks for single antiplatelet.
And does it differ between devices, between Contour and Web?
Not actually.
Okay.
It's the same for both of them.
Everything is looking okay. You would still have one antiplatelet for a
4
month.
weeks. So that is what my practice is.
If possible, I have a quick question. Cirrus have 2 devices, so it's the Contour and the next stent. I'm just wondering, everyone sort of mentions Contour, but no one mentions the next stent plus coiling. So I'm just wondering if there's a specific reason people tend to go for Contour rather than next stent coilings. Is that partly cost implications? Is it just speed? What's the reason? Because I think the long-term results are going to show next stent plus coils is far more residual. You're going to see far better results. This is what's coming out of the UK. Far better results with next stent plus coils than Contour. And this is our own experience as well.
Okay, I would have one of the panelists comment about it. Rajiv, do you have a comment on this?
Not really, but I would like to know from Paul as to what is are you trying to say that you have recurrences with Contour, and what percentage, if I may ask? Sorry?
So what we've seen is that at 3 to 6 months it looks quite good. We don't have a lot of experience, certainly not as much as the panel. But what we've seen is that 3 to 6 months, often it looks great, perfect. And then at about a year to 18 months, something's drastically changed and you've got a recurrence.
Uday, can you hear us?
Yeah, Vipul,
yes,
up to you.
So you saw we have managed to pull it back now, all right?
Yeah, now
Now
it's
looks
better.
Yes, we could see that.
And Nitin, do you give the approval?
Of course.
I'm in awe of you, So it was, we took some blank roadmaps and we tried, so it has come back. And I don't think I can pull back, because you see the upper MCA is at a very reverse angle, and I think anything more than that may not work. The marker is in the artery now. The neck is by and large covered. If you ask me, very, very, maybe teeny mini neck on the lateral side, maybe, but this is a tricky trifurcation case. So it has come back by a millimeter. I think we are okay with it now. All right, we'll detach this one and then we'll try to do the other one. All right, yeah. Is it okay?
Yes.
All right, Michael.
Vipul, we have a talk right now, so we are going to come back to you. And may I invite Osama for his talk right now, and then we go back to Vipul. Osama, please.
My talk is a little bit long, but those cases go very fast. He'll be probably 5 minutes, and he's going to do another contour for the other aneurysm. That's the plan. Excellent. Well, thanks for inviting me. It's kind of like really related topic in a way about intrasaccular aneurysm treatment, and let's see if they can pull the talk. 6, maybe session 6. You want to do it from this side? Okay. So basically, this is a journey that we started with the 3 other neurointerventionalists. Started early in my career when I was at Duke University doing a fellowship, the idea of one and done. I think Paul heard the story before, like the jellyfish device. When I had kids, now my oldest is 24 years old, and when he was like 3-4 years old, when we used to take them to Shedd Aquarium in Chicago, and we used to watch the jellyfish. I was fascinated by the jellyfish, which is kind of like the bridging part of the neck, right? The filter, the body of the jellyfish, and the tentacles. The original device we thought of is really more or less a combined coil finishing with a bridging device. We have actually a patent on that idea, to put a coil in, one coil, to give you an anchor. We never thought like the contour people, just like a lens-like, a concave lens-like device will sit there. And there is recent case report in JNS that the concave contour flipped and converted and became, convex versus concave. So kind of like we always wanted to put something toward the dome of the aneurysm. So with that being said, so the journey started years ago, and as a physician who started the company from an idea, at one point, at one time, we will share with you more detail of how difficult those journey can be. From an idea on a napkin in Caribou Coffee. Caribou Coffee is a famous one in the Midwest, in Minnesota and Wisconsin, to really a company with a brick and mortar and 10 employees, and paying salary for 10 employees before you even start selling any device. It's a fascinating journey. And kind of you have to wear a hat of an engineer. Can I go page down and page up? Some of this talk we shared with the Brain Symposium in London. Since then, these are my disclosures. Since then, we have added 7 more patients treated in Karachi in Pakistan, which is kind of, to me, it's really also as a physician is very satisfying when you go to India and Pakistan and treat them within the research And those patients don't have, means to really afford those devices or to be on dual antiplatelet for 10 months or for 1 year or 2 years, whatever you want to treat them. So we're going to share with you a little bit of this journey of developing the SEAL device, which is saccular endovascular aneurysm lattice device. So we know the problem. The issue is wide neck bifurcation aneurysm. There is unmet clinical need for this problem, and those are some of the aneurysm we tackled in the pre-SEALIT trial. So the solution can be like a multiple coil, stent-assisted coiling, balloon-assisted coiling, clipping, pulse rider with coil, neck stent with coil, as you can see, or it can be a simple solution, which is the one and done solution. This is an example of a SEAL device. We treated a patient, then this is the MCA 1 year later. Similar to what you guys have been talking about, the marker band has to be in the parent artery, and the device has to almost herniate down to really have a complete occlusion. Another example of a SEAL device is an ICA terminus aneurysm, and this is after treatment. There is issues with the current technology. As a physician entrepreneur, it was hard for me to beat people who are full-time CEO, but I went in full gear 4 years ago, although the idea was 20 years ago. When I talked to AJ Waklu about the Surpass, he said it's almost like that for physician. We sit on the idea until other people come up, and then we go on full gear. If you look at the web device, it has this lead-in marker band, which worrisome. I showed a case in Abu Dhabi, in a Cleveland Clinic, Abu Dhabi, about the problem and disadvantage of having a lead-in marker band. So the lead-in marker band has story, I'm sure, with the web device, and I'm sure it's not necessarily because it has to really be there. Early on, the braid were not radio opaque. So they have to put a marker band at the end and a marker band in the beginning until the technology evolved, and now those braids, you can see them. So that's kind of like the story with this. And also the square shape of the web device, it doesn't really make it easy to conform to the aneurysm, right? It doesn't really conform to the aneurysm. Very stiff, square shape, and you're gonna push with the lead-in marker band, which you can rupture the aneurysm. The contour has an issue, right? The contour could really flip. It doesn't have any anchoring. It's like a lens, as you can see, and that's what I see what Paul talking about. Maybe the next stent with coil may have a higher occlusion rate. So there's a problem with it, and this is a case report recently published in the JNS showing the device when they deployed it here with a dotted line, and they come a year later and the device like almost flipped, became instead of concave, convex, as you can see, and they outlined the device here for you. This is the marker band, completely reverse its shape, which makes sense sometimes. If it doesn't have enough thrombosis to hold it in place and you may be undersizing it, it may really become like that. So the solution is to come up with something for shallow aneurysm. And when I first saw the label for the web, it's a 3 to 10 millimeter aneurysm, 3 to 10, the label. However, I had first aneurysm to treat was an MCA aneurysm, what I call them the hammer shape, right? It's an 8 millimeter in width and only 4 millimeter in height. That's really meet the IFU, meet the label. So, but it doesn't fit. That's not a good case for web because it's flattened. It's a shallow aneurysm. Shallow aneurysm is not good. So we came up with this wavy base idea, which is the SEAL base. And the SEAL arc, we came up with this idea that there is another member of the device that keeps it in place. So this is kind of like see if we can play the video. Let's see, we can play. This is kind of deployment. The videos are not working. Let's try again. Here it is. So this is the device. It has this wavy appearance, which is kind of makes it anchor more, less likely to compact, less likely to herniate, because it has more surface area for the clot and for endothelialization. And this is kind of the deployment of the device here. Can you play the video here? So similar to what everyone has been saying, you have to bring it to the neck and keep it there. So it's very critical when you deploy those devices to bring them to the neck. Next slide. Okay. This is an interesting experiment we did at the University of Toledo in Ohio. Can we go back to that video? I don't know why it jumped back. Can we go back? Page down, page up. Yeah, page down, page up. Yeah, this one. There's a video here. Can you guys? Yeah, excellent. So this is a very fascinating experiment. I've done it all, the 11 cases. I deployed the devices, and the lab, the visual optical lab, is actually a high-speed camera with particles like an RBC. And this is actually now, you're seeing it without any device in it. So we compared on the bench the flow within the aneurysm before the seal device and after the seal device. And you can see what happened to the same aneurysm after we implanted the seal device. Let's play the video on the right-hand side. And here it is. You can see instantly on the bench, almost flow cessation completely within the aneurysm sac. This is an MCA silicon model before the seal device and after the seal device. And we went through this. So we talked about it, the simplicity also. The challenge is the sizing, right? We all don't like the sizing. Contour has issues and this. So we come up with a sizing, as you can see, up to 9 millimeter, it's only 3 sizes for the base, only 3. In an increment of a 3, simple. Anything is 3 or less, you choose a 3. Anything 6, you do 3 to 6, 6. 6 to 9, 9. You're done. You don't have to measure anything else. You don't have to complicate it. Then 12, then 15, 18, and we went all the way up to 20. It's very challenging to come up with the larger devices, so we managed to get up to 20. As you can see, a very dense mesh. This is the final device. This is the actual handle, and the wire. Our wire, push wire, is 200 cm wire versus the web and the contour, which is 176, which may be shorter when you are using a longer microcatheter. So the seal device, seal arc, and seal base has a longer wire. And again, you start by looking at the aneurysm. If it's shallow, you use a base. If it's deep, you use the arc. And here is my simplified chart. So you're not going to have a big chart that's complicated in the angio suite. It's a simple chart. If the aneurysm is flat, you're going to think of the base. Then you measure the width on AP or ladder, whatever you want to measure it, the width. Now, any device next to the width, up to 3 millimeter, you can oversize, up to 3 millimeter. So if the aneurysm is 7.5, you use a 9. That's pretty simple. If the aneurysm is 11, you use 12. If it's 13, you use 15. So very simple sizing. If it's deep, arc. If it's shallow, base. And you go up more than the aneurysm width by up to 3 millimeter, by up to 3. So this is the label. And we talked about the pre-seal. Then after we did the bench testing, after we did the animal testing in Austria with Matt Gunas, and we just finished actually writing the paper with Matt Gunas from UMass, and it's going to JNS next week. So we did after all this data, we started the human study, the clinical experience. And we designed it to look at the 24 hours angiogram before the patient goes home, and then 3 months, 6 months, and 1 year. And I agree with Paul, those devices need to long-term follow-up. 20 to 80, ruptured, unruptured. We decided to tackle sidewall. And I think there's an advantage for those devices in sidewall, because you don't need to do surpass, you don't need to do pipeline or a FRID, and then you can send the patient on single agent, like most of the people here says. So I think it can really make a big difference. This is our human data. We've done 33 aneurysm in Pakistan and Colombia, and I think countries like India, Pakistan are a great opportunity to bring a new technology to you guys. And I can also give a talk down the line about how can the innovation be in countries other than Europe and USA, early visibility studies. So we treated 33 aneurysm. We looked at eligible for 24-hour. All of them had an angio before they went home, all of them. So we have the first study to have 24-hour angiographic outcome, 24-hour on a 33 aneurysm. Now, 7 in Pakistan and 26 aneurysm in Colombia. After the 24-hour, we looked at the 3-month data. The 3-month data, people who are eligible for the visit are 26, and all the 26 completed the follow-up. And then the 6-month data, 26, and all the 26 now, as of today, completed the follow-up. Boris Babon have sent me the images on the 6-month data. The 12-month, we have 9 patients yet. 9 patients or 9 aneurysm with 1-year follow-up. So it's very early. So in the 26 aneurysm we treated in Colombia, 15 women as usual and 7 men. The sidewall aneurysm, we treated 4 sidewall aneurysm versus, and then we treated another 2 in Colombia. So 6 out of 33 or 25% of the 33 aneurysm were sidewall, which is critical. The base, and there is, you know how in the web, you either use one or the other, almost 95% of the shapes are one shape. The base and arc, there is an actual utilization for it. So in the beginning, I was thinking we may drop one of the shapes, like the web. But when you look at the use and the utilization, there is equal use, 50-50 of the base and arc, which is really good. The radial approach was 5 and 21 was non-radial approach. And the fluoroscopy time was 21. We didn't use any balloon or a stent or bailout approach or technique in any of the cases. The sizing was in the beginning was an issue until we figured it out with this. The detachment early on, most of the electrical detachment, even now in the web, there was recent issues with detachment. We work on the detachment, and the most recent cases, we had faster detachment with less attempt. We looked at the occlusion rate and the angiographic outcome. Complete occlusion A and B, web A and B, in the procedure was 57%, 80.7%, and 24-hour. This is what happened at the 24-hour, 80% A or B, 80% A and 24-hour. Adequate occlusion was 96%. Sidewall aneurysm. So this is a superior cerebellar artery. We all agree this is very challenging, like similar to the case that you guys showed now. The SCA coming right from the neck, so we had to use a device and push it forward in the sidewall. And this is, let's see if there is a video here to show. Can you play the video on the right-hand side, please? Okay. See, for the sake of the time, here's the device. We use the base device here on it. Let's see if we can play the video here. Okay. So, but this is the 6-month follow-up on that aneurysm that you saw. So I'll go back to the aneurysm. Here it is, with an SCA coming out of it, superior cerebellar artery. And this is a 6-month follow-up, and the SCA remains open. I think to keep the artery open, we all accept this neck to keep the SCA open and avoid an SCA aneurysm. And this is the 3D out of it, completely sparing the SCA, and 6 months. I would call this probably grade B, but it's very adequate occlusion, as you can see. If you pull it down, this one, probably you can't pull this one down. I don't know if you will pull it with the contour. If you bring it down further, you may really cover the SCA. And if you cover the SCA, it may completely shut it down. So this is the 15 patient at 6 months with DSA, all had A or B. Complete occlusion defined as A and B is 93%. Adequate occlusion is 100%. Look at this MCA, very wide neck, similar to the case you guys just showed. Very hard to treat with a stent assisted because of the takeoff of the branch is backward. And we did the same thing here. And this is the 6-month follow-up, complete occlusion. And this is the picture of the endothelialization. Let's see, yeah. This is another large ACOM aneurysm with using a 9mm device, 9mm. This is a fenestrated basilar artery with a bifurcation aneurysm at this, and it's very shallow. We did it radially. Let's go ahead and advance it, yeah. This is the same aneurysm We did this aneurysm radially. Let's see. Yeah, this is 1 year follow-up on the same aneurysm. We did a base device and still closed at 1 year. From the 8 cases we've done at 12 months, we have A or B at 100%, not A or B. If you look at Raymond, it's about 77% Raymond square. Still very high comparison to the web device at 1 year, but 8 cases only. This is the, see, I think. This is just showing the device opacity. The arc device, because the leading arc is, the braid is smaller, so less opaque. So it's very important that you watch the leading loop of the seal arc versus the rest of the double metal. So there's double metal here versus this. And this is the device fully deployed. You can see the base part of it and the loop part of it. See if we can show the detachment. Can you try to play the video here? No? Okay. We'll skip the video. This is the follow-up at 1 year, complete occlusion, the MCA aneurysm, still complete occlusion. This is an interesting pericallosal artery aneurysm, very distal, as you can see, irregular in shape. And this is immediately after we deployed a base in it. And this is the 24-hour and then 6 month. And the 1 year follow-up. But like, I don't want to overwhelm you with pictures. We have, at least like we mentioned, significant follow-up. This is the picture of the device, is still not detached, just showing immediate occlusion example. I'm sure other devices has similar immediate occlusion examples. We think the device that we developed has ease of use, efficacy, and durability that probably superior to what's in the market right now. And that's what we are planning to do a clinical trial starting this summer in USA that will lead to USA approval. We've done it on ruptured aneurysm. This is an MCA trilobulated aneurysm. As you can see, it's ruptured, and we used a 9 millimeter device on it, 9x3. And this is immediately after deployment. And this is the 6 month follow-up. This is a ruptured aneurysm. As you can see, at 6 months, completely closed out. Sidewall aneurysm. I think we are going for the clinical trial for sidewall aneurysm as well. So we have treated about 25% out of the 33 aneurysm as a sidewall aneurysm. This is an ophthalmic aneurysm, and we put an arc device. So from the 26, we didn't add the 33 cases. We just did the 7 cases in March in Pakistan. So this is an analysis of the first 26. No mortality, no morbidity, minor. So it's a kind of like just, I think, minor or transient and procedural thromboembolic event. None of those patients were on aspirin and Plavix unless they are on aspirin and Plavix for coronary indication. So none of our patients came to the procedure with aspirin and Plavix in case of stenting. Only few patients and were on aspirin and Plavix for the coronary indication. Again, there is some limitation to our data. It's non-randomized design. It's early experience. It's a small series of 26 aneurysm. Again, but it's really very promising. The MRI, we changed the wire in the MRI to be a little bit less artifact than the web device with the MRI. Again, if you look at our data, we went over it again. So I think it's very promising technology. It addresses the shortcoming of the current technology and add to its efficacy and simplicity. And this is the team that we did most of the work with. This is in Austria, the animal studies with Dr. Monica. And this is the team in Colombia, our first case. We were very excited about our first case in Colombia and multiple other cases. This is the team that we travel with to the animal studies and to the human studies. Thank you very much. Stay tuned. stay tuned. We have now 33 aneurysm we're going to present on, and we are thinking of a global seal registry. If you guys are interested, please just feel free to email me. Thank you very much.
Thank you, Osama. Congratulations for a fantastic new device. And I'll let you absorb that because now we need to go back to the cases. We have 3 centers ready, and the first one is going to be Australia. Interesting journey. Welcome back again.
Good afternoon, did you hear us?
Yes, we see you, we hear you.
Yes, thank you very much. Thanks for having us back again. Meanwhile, we were getting an access for the second case and making everything ready. We go back to our fellow, Dr. Dalbo Fermel, and he's going to have an introductory talk very briefly again about our service and this case. And then we'll come back to me and I have some extra explanation. Thank you.
Thanks, Ahmed. So this is Dalbo here, the fellow. Just briefly for those who missed the first case, we are operating out of Melbourne, Australia. We work across 2 hospitals, Austin and St Vincent, which you can see are beautiful hospitals there. We have 3 biplanes across both hospitals. We're working on the new Siemens Icono today, 4 consultant neurointerventionists, 1 fellow, and a wonderful nursing and radiography to support what we do. So this is our team here. The service is led by Associate Professor Mark Brooks, and we also work with Mr. Jeremy Russell, who's a neurovascular surgeon. This is our wonderful nursing and radiography team. This is the senior members of the team, and we're very lucky to have excellent anaesthetists who are very supportive and responsive. So this is the case that we're doing. This is the second case today. So it's a 68-year-old lady who presented with an incidental unruptured right MTA aneurysm. She was previously high functioning and independent. Her past history...
Sorry to interrupt you, Dr. The slide hasn't moved. Your slide has moved, but we cannot see the new slide. Can I double check with Delhi that we go to the... Yes, thank you very much.
Yeah, okay. Can you see the slide?
Yes, now we have the case.
Okay, great. Past history of lumbar radiculopathy, migraines and reflux. And last year she suffered a HSC encephalitis, which she's made a pretty good recovery from. But during the workup for that, she was found to have a right MTA aneurysm. So this is the measurement on the MRI time of flight. We don't typically do cerebral angiograms in the workup of our cases. We usually work off non-invasive imaging. Here we can see it's a wide neck, quite a tall aneurysm with measuring about 4 to 5 millimeters across. On this MRI time of flight, it looks like the superior division is incorporated, but as you'll see on the 3D we show later, that's actually not the case, so that makes it less tricky. We thought it might have to be stent assisted, but we may get away with just the web. So the treatment plan here is we've got access with femorally here, a French. For our femoral cases, we often use a BMX guide catheter, and we typically use just a PS6 as the intermediate. And the reason for that is that we can have both the balloon and the VIA. So we've got the VIA 17 and the Scepter XC. And the web we initially off the MRI thought we were going to do a 6x4, but as we'll talk about in a moment, probably needs to be a little bit bigger than that on our 3D. So just briefly before I go to Hamid, so the other options in this kind of case is clipping. So a lot of our MTA aneurysms are clipped. However, in this case, it was patient preference to have it treated endovascularly. If it's narrow neck, we'll do coils, or potentially stent coil is another option here. We typically use the Evo stent, which is a very good, very visible stent. Flow diverters are sometimes used as well in this setting. And the contour device is another option that we've been talking about this morning that we have some experience with. Hamid, did you want to make any further comments?
Thank you very much, Davor. We just turn off the fan here so that we don't have echo. Thank you. Yes, as was mentioned, the proaxial system that we are using is BMX, Sophia-6 range. We like to have the Sophia-6 range normally in distal aspect of the artery that we have aneurysm over it. Even if it was an ACOM aneurysm, we normally like to put it in A1. That gives us stability as well as the lumen that we have for having different carrier balloon or integrity of the branches. BMX is our new workhorse, replacing the Neuromax for us. It gives us the ability to have proximal run because of the extra lumen that we have beside the intermediate catheter. Initially, we wanted to advance the BMX to the base of the skull. Dr. Kabata and Lingard tried to do so, but this patient has FMD, and there was a bit of a twist induced by the stiffness of the BMX and compromised the distal flow. Therefore, they pulled it down and they just advanced the intermediate catheter into the MCA. The original measurement, as was mentioned, was feeling for a 6mm device. However, on the CT, on the angiogram, we noticed that either the aneurysm is inaccurately measured on the non-invasive or has grown interval since the time that was measured with MRI, because it seems to us now that the aneurysm is suitable for a 7mm device. It looks like conical, which makes it slightly difficult to have a very precise height measurement because you will have compression from the top. It would be great if my colleagues can actually magnify that in the 3D on the lateral, if that's okay. The other projection, please, the lateral projection. Yes, that one, thank you. So you can see the conical appearances of the aneurysm. As I'm sure the esteemed audience and panelists, they would appreciate sometimes measuring it based on the largest diameter is a bit problematic because you have compression from the top and you get elongation of the device. We decided eventually to try a 7x4mm device first. If we see that it is too long and it's encroaching on the MCA bifurcation branches and divisions, then we are going to move to a 7x3mm. Please, if there is any question. Any questions from the panelists and the audience and the Sheikh?
Ajay,
It's okay.
is there any comment or question from all of you panelists? They are in unison. I mean, they agree with you.
Sorry, I didn't hear what you said. We are cannulating the aneurysm now. Sometimes we notice that B actually catches at the edge of the MCA aneurysms in particular, which we have a few tricks. So this one wasn't the case. It was possible to go in relatively smoothly. The configuration is relatively simple. But we have noticed that sometimes we have a slight disparity between the size of the wire and the edge of the via. In particular, if it's the via 27 or 33. For 33, we try to put microcatheter inside. For 27, sometimes we put 2 microwire inside to be able to straighten the microcatheter. Our practice is normally to place the tip of the microcatheter as close as possible to the dome of the aneurysm, and we like to unsheath the device from the dome of the aneurysm, of course having the safety in mind, because the device at the time of being introduced is quite stiff and sharp, as you know. So my colleagues, Dr. Maygard and Faza, they are actually introducing the via. One thing that we do slightly differently is we normally do not open the device in a bucket of water. We normally backwash the device through the TUI bores. We notice that sometimes when you open it inside the bucket, you get the air trapped inside the device, which makes it very difficult to get rid of. The large devices, sometimes it's good to be opened in the bucket because you can have a bit of a motor memory, you know how much force you need to apply if you want to retract it. And that practice inside the bucket of water can be actually helpful, at least in our experience. Because large devices can be very difficult to collapse and retract. So the position of the microcatheter appears to be quite stable. The device comes up. In our experience, we have noticed that specifically with large devices, across the curvature, you need to have a bit of a pause because sometimes we have a abrupt movement of the microcatheter when the large device is introduced. So I think Dr. Maingard is going to do so, and you can see at each curvature, he pauses momentarily to be sure that everything is stable. As you can see, we're just crossing the project terminus. It's important to say that we normally have these sort of aneurysms clipped. This is the practice that we have, and that's a very collegial relationship with neurosurgical colleagues of ours, but this particular patient, because of medical history, was deemed to be appropriate for endovascular, and that was the desire of the patient and the family as well. So the device is getting closed. We like to keep them almost tip on tip, and at that time we like to actually gradually unsheath it. I may keep the room quiet so that my colleagues can concentrate. So we're just saving that blur loop that we can have a quick look again. If my colleagues outside can actually show us the loop again, please. There was slight instability in the positioning of the micro catheter despite the very distal positioning of the Sophia, and you could see that it suddenly dropped down a bit. But I think as soon as Julian was happy with the amount of flowering that he had, he actually pushed the entire construct in and parked himself again against the dome, so you can see the fluoride. We're doing the run now. It seems that the web is centered well. It seems that the divisions superiorly and inferiorly both are clear. So we may do a slightly more vigorous injection to be sure about the patency of the branches.
Hamid, it looks good, right? Right now, we will have to switch to another center, and we will come back to you. We were waiting for the exact moment that you deployed the device. We will come back to you, and let's switch now to Vipul, to Artemis.
Sorry, can I please repeat the question? It was a bit noisy, I couldn't hear.
No, we were saying that we will have to switch to another center, and we'll come back to you. It looks good. We saw your
If you don't mind,
deployment.
it was 2 minutes. We detached the device as well, just in case that there is a hiccup at the time of detachment, which might be useful to be broadcasted. So give us 2 minutes. We'll actually detach it now. I think my colleagues are looking to just be sure everything is okay for the detachment, and it looks like they're proceeding to the detachment. I think my colleagues outside can actually focus the camera. Yep, so we normally try to keep the microcatheter distal so that we can have a bit of a hold over the nipple and the body of the web device. As you know, again, there is a significant stickiness between the pusher device and the nipple of the web, so you need to be mindful to not inadvertently pull it down. I think what Julian is doing now is actually checking to be sure that the wire is detached while the microcatheter is holding the device in place. If we can have outside, if we can please have the non-subtracted images captured. We're just changing the video feed for you so that you can see the non-subtracted images. Yep, so we have the non-subtracted image now. The device appears to be detached, everything looks in place, we'll take it out. So thank you very much. We can give the video feedback to you guys, and then if in a few minutes coming back to us, we'll show you the result of the Vital CT.
Sure, Hamid. Thank you very much. And we will come back to you. Let's switch
Thank you very much.
to Artemis. Vipul, you're back, and we apologize that you had to wait on the catheter a little, but now you're on.
Dr. Vipul, can you hear us?
So, hi. Uday, can you hear me?
Yes.
And we apologize that you had to wait quite a bit for this.
So it's all right because I just delivered the second one.
Okay.
All right. And we have recorded all the steps. Okay. So can you see the DSA now?
Yes, sir.
Yeah.
Back, 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 back. So can you see, we got the device. It is still, of course, not detached. Forward. Stop. Now, in this case, of course, so let's do a CD angio. Let's show them the perfect roadmap steps. Just go to the microcatheter placement. So I'll just show you all the recorded steps, all right? All the Okay, start from here. Yeah. So we did a reverse curve to the microcatheter because this aneurysm was pointing at a reverse manner to the main MCA. So this is a headway 21. We did a reverse curve and I just wired the aneurysm a shape and slowly when it went in, the reverse shape kicked in. Okay. So at this stage, I do carefully. With other plane, actually it was tending to touch the wall. So I just took the microcatheter in like this. And then the reverse shape is working in our favor because I'm now pointing in the direction of the aneurysm. Alright, next. Yes.
Vipul, what do you mean by reverse shape?
We do a.
Catheter ka recorded.
We have recorded it. I wonder whether they can show. So reverse shape is something like this. Can I pick up the previous micro? Can you focus on the hands? So like we give it one curve usually, right? Like this. Can you make it out? Okay. Can you show me the shape of mentally?
Yeah.
And the reverse shape is in the opposite direction. That means I have given it like an S. So what you can see, this is the shaping mental. All right. So there are two curves in opposite direction.
Okay,
right?
understood. Yes.
So this is what we did. And go next. So now we'll go to the device placement step. Again, the guiding was backing off. It wasn't so easy. This is a 9mm device, by the way. Forward. Forward. So again, this is the device going in. Yes, CT angiography dike. Okay. So we have to be careful. In this case, if the microcatheter come out of the aneurysm, I could have re-entered easily because again it's at a very tight angle. So we took our time. Next. So again, I need to come out, try to push it back in. Next. So we have taken it up again up to the dome, and then slowly. The advantage of reverse shape is pointing in the direction of the aneurysm, which make our delivery much easier. Next. And then slowly, of course, we withdrew and pushed it up. Next. So sometimes we take this, take single shots that tells us what's really happening. Next. Yeah, so now the microcatheter is backed off a bit and I pushed out the device at this stage. Again put in some pressure onto the micro and then we delivered it. Here you saw, it has been completely released now. Next. DSA. Okay, single shot, if you can make it out, the device is well open. Looks fine. Next. This is the DSA. Okay, so maybe at the lower part of the aneurysm, a little bit of wedge will remain, but that will remain here because it's a very dysplastic looking aneurysm. So we'll do a CT angio now, okay, to look at it. All right. But I don't see too much scope of manipulation. We'll see whether we need to withdraw it a bit, but maybe we are okay with it. All right. So we'll just do a CT angio. Let's do it.
Okay. So when he's on CT angio, there's a question here from the audience that what dilution of contrast is used in vaso. So what are our panelists using, Rashmi? What dilution for vaso?
I usually use 20% dilution.
20%.
So we use 20% dye, 80% saline. Okay, and then of course once you acquire the image, you reconstruct in small view and in a higher resolution in a stent configuration, and that is very comforting. Although as I said, in this case we may see bit of neck in the lower part, but the artery arising at such an angulation and the way the contour or any intraceptular device is placed, I can live with it. Otherwise, this aneurysm would have required a stent at a very acute angle and trapping the other aneurysm. So I think I'm okay with this. Let us see how it shows up. Yeah.
Okay, Vipul, I'll have to put you on hold as we have to go to Gangaram to see what Manish Chugh is doing.
All right, great. Thank you.
Vipul.
Nice one, Vipul, nice.
Thank you.
We close the session because
Dr.
Manish
Gaurav.
Chugh is not there.
Dr. Gaurav,
so
how can we, how I can be two places at a single time?
I would
I
like
can
to inform all of you that we do have flash workshops happening right now, exactly starting at 10:30 a.m. at Bolt Tech Studio 3 and Striker Tech Suite Studio 1. As you can see, anybody who's interested to view these flash workshops are requested to start moving to the required area. I repeat, exactly at 10:30 a.m. at Balt Tech Suite Studio 3, we have a flash workshop, and the second one is happening at Striker Tech Studio 1. So please start moving there. And of course, this session has been quite remarkable indeed. Can we have a round of applause for our moderators as well as for our panelists for taking our time, for diligently curating this entire session. Thank you so much.
Okay, thank you. So this session is closed and we hand it over to the next moderators and panelists. Thank you.
Thank you.
Thank you once again. As we move forward to our next session now, I hope you all are as pumped and energized as I am. For our next session, I would be requesting the humble presence of our moderators now, once the photo op is done. Thank you once again to the dignitaries for giving us your precious time here today. Our next session, I would request the humble presence of our moderators henceforth, starting with Lauren Perrott and Rajiv Shivasankar. Let's welcome both of them with a round of applause, please. Followed by our panelists for this session, Anand Alurkar. I repeat, Anand Alurkar, Sukalyan Purkayastha, Yong Samshin, Rashmi Saraf, and last but not the least, Siba Sankar Dalia. So let's welcome them with a round of applause as we commence forward for our next session now. So in the meantime, as our panelists and moderators are settling down, we can have a small icebreaker activity to energize one and all. So I can see so many bright young minds here. So the task is quite simple, not too much to do, but just to energize and pump each and every one of you. To all the wonderful, wonderful people here, can we raise our right hand? Come on. Start raising, stretching it out. Stretch, stretch, stretch it higher. I would request you to close your eyes simultaneously and try to envision your year-end goal. It could be, your next promotion, your next house, a luxury car, your next holiday vacay. And I would request you to clench your fist and then unclench it. Keep doing it. Breathe in, breathe out, breathe in, breathe out. People at the back, this side, I'm looking. You have to participate. We need your humble participation. Raise your right hand up. Come on. Breathe in, breathe out, breathe in, breathe out, breathe in, breathe out, breathe in, breathe out. Wonderful. You can relax. I think you've already burned 500 plus calories now. I think we are all set to go for our session as our panelists are here as well. So is the moderator. So I would request our honorable moderator, sir, to please commence the session forward. Thank you.
Thank you. Okay, so we now move to Gangaram Hospital, where we have Manish, Dr. Manish, who is going to be treating a few aneurysms in a single patient. It's a very interesting case, and I think Gaurav will present the case.
Yeah. So I'm presenting on behalf of Dr. Manish Chugh. So it's a very interesting case. A 60-year-old, she had complaints of gradual blurring of vision in the right eye and followed by blurring of vision in the left eye. So this is the visual findings. That's the only positive finding. So this is the imaging of the case. Plain CT showed a chronic infarct in the right occipital lobe. I do not know what's the significance. And the CT angio was performed, which showed a pseudo aneurysm in the cervical segment of the right ICA. We'll show the DSA picture soon. And saccular aneurysm in the supraclinoid right side ICA, and a small bulbous dilatation of the right MCA. So these are the DSA pictures. So we can see the cervical ICA, aneurysm, supraclinoid, and a small MCA. There's also an, which Manish feels is a blister aneurysm, which is arising from the left ICA. I do not know if it's cavernous, maybe superior hypophyseal. So he has a big treatment plan, but let's see what we want to do. Can we have the poll, please? So the first thing is, will you treat this left ICA aneurysm? So I can try to put the picture back there, yeah. So how many of us will try to treat this left ICA?
So how old is this patient again?
So patient had...
and how old is she?
60.
60-year-old
male.
60.
60. Okay, I think we are a bit sleepy or no? So only 2 responses and they are equally divided.
So we can do a show of hands. So how many of you would actually treat this left ICA aneurysm in a 60-year-old, unruptured, small, maybe a carotid cave or a superior hypophyseal aneurysm? Can we just have a show of hands of how many would like to treat it? Can just raise their hands. So the vast majority, okay, this is a smattering. So most would conserve, I guess. Maybe Sukalyan, what about you?
Yeah, actually that depends on how you treat the other 2 aneurysms.
Yeah, so I don't know what the plan is, whether you're going to treat, he's going to treat the right side first and then come
right
back.
side, left side?
All 3, so we don't know the...
Okay, like if you have only that small carotid cave in 62, probably you'll conserve. But if you deal with the other 2 aneurysms, which are quite large and they have a potential to rupture, so obviously the other one is to coil and stent or flow diverter. So obviously you are going to put the patient on antiplatelets. So why not treat the other one? Because we have seen a lot of rupture in carotid cave as well.
Professor Saw, do you conventionally treat both sides at one time? Dr. Saw.
Me?
Yeah.
Yeah. My name is Shin. Last name
Shin,
Shin.
sorry.
Anyway, I have one question. So because about to clarify about nomenclature, why does he put the blister aneurysm on the left side, just paraclinoid aneurysm? Why they put the blister aneurysm on this case?
Yeah, that's probably a misnomer.
Right.
It's not a blister, but that's why we said it's either a cave, small cave aneurysm or a superior hypophyseal aneurysm. We'll see. So, but do you conventionally treat both sides in one sitting?
No, I don't think I'm going to treat the left side one, but I just only to focus on the right side I see one.
Right.
I'm not going to treat the left side one.
Right. Dr. Alurkar, any thoughts?
Always different settings. This left one I would not treat at all, but if at all I had to treat, I would do it in a second stage.
Yes, so you would also like to conserve. Siba?
As for the question is concerned whether we treat at all or not, I would like to treat. And that would be the right side, both of them, the carotid as well as the cavernous one.
And would you first treat extend the carotid and go up? Okay,
no.
So we will hold on to the thought. We'll go to Manish now. Hi Manish, this is Rajiv. Can you hear me?
Yeah, Rajiv, morning. Good morning to all the panelists and all the other colleagues sitting there. I think you all must have seen the imaging, and probably there was a lot of dilemma. I mean, I was also facing the same dilemma whether I should treat the left side or not. But as Sukalyan said, it all depends on how we treat the other side. Basically, if we want to treat the right side nicely, we have to put a flow diverter on the right side, because the right side aneurysm is a very broad-based aneurysm. And plus, for the lower cervical ICA pseudoaneurysm also, we need to put in a kind of a stent graft or a C-guard kind of a stent. So for both these aneurysms, we will be required to give dual antiplatelets. And with